So this was a single-center retrospective study that looked at risk of Richter's transformation at progression for patients treated with ibrutinib. So this was an extension of another study that I had done previously looking at karyotypic abnormalities in patients treated with ibrutinib. And for this study, all of these patients were treated with ibrutinib either in the relapse setting or in treatment-naive setting. And we looked at everybody who progressed. And the idea was, at progression, should you be thinking about Richter's transformation for patients who were on BTKIs, and how we should be thinking about it. And the reason why this is an important question is that there's data out there that shows that patients who progress on BTKI have lower SUVs on their PET CTs, and so it may be more difficult to identify who has Richter's transformation, who you should pursue a biopsy to look at whether or not they've developed this transformation event. And so we looked at various patient characteristics at progression and specifically focused on the iwCLL criteria for progression to help us really think about different variables in a very evaluated and defined way to help people really inform them on when they should be thinking about this event at progression. And ultimately what we found was that patients who progress with a specific phenotype of lymphadenopathy without lymphocytosis at progression have high risk of that being Richter's transformation. So basically what we're seeing is that rapid expansion of lymph nodes is what we see in Richter's transformation is really a sign that this patient has developed Richter's transformation. Those patients not only had a higher likelihood of being Richter's transformation, but also had a lower overall survival. In addition, we found increasing LDH to be prognostic of Richter's transformation, and also patients who progress on therapy, right? So when we're talking about BTK inhibitors, a lot of patients will have stopped therapy due to toxicity potentially. And so if you progress on the BTKI itself, it is also associated with Richter's transformation. We had some data too about complex karyotype and deletion 17p, but we had a lot of missing data, so it couldn't be included in the multivariable analysis. But on the univariable analysis, those were also associated with Richter's transformation. So I would say that if you have somebody who's progressing and you're unable to get a PET scan, that if they're progressing with very high LDH, they're having very high lymph nodes, big lymph nodes without lymphocytosis, those are the patients that you really should be thinking about biopsying, because those patients do have a high likelihood of having Richter's transformation. I would say that PET CTs are still important, and that if someone's progressing on therapy, that we should be using a lower threshold for an SUV cutoff of when to consider biopsy, especially if you have those other characteristics that are occurring at progression. So usually I use a threshold of 5 still. So if someone has a SUV greater than 5 and they're progressing with those other variables, then those are the patients that I'm really thinking about ruling out Richter's transformation. And the reason why this is important is because there's really no standard of care for Richter's transformation. And in order for us to figure out what the standard of care might be in order to make these patients have improved survival, is we need to be better at identifying them. And so using these variables to identify patients with Richter's transformation, especially now that we typically only use small molecule inhibitors for the treatment of CLL, is really an important thing to identify.